All right, so I'm going to go through, before we get started, I'll go through a couple of our general guidelines here. So as a reminder, if you have video, it would be great if you are able to turn that on. That way we can see your shining faces. As well, try and make sure that your line is muted at all times. We get a lot of background noise that makes it hard for people to hear. And if something happens, we understand, we're in healthcare settings, things come up. Just please don't put us on mute if you have to. You can leave the meeting and come back in. I'm sure your hold music is really great, but we don't really want to hear it. So if you have to leave, that's okay. Just hop back in if you can. Just try not to put us on hold. And I will try and make sure everybody's on mute the entire time. Finally, again, if you could put your name and agency in the chat box. And we'll get started in just a minute. We have Lori Sadowski here, who is going to be doing our webinar today. She has worked at the Star Health Center at SUNY Downstate for the past 8 years. She started as a patient navigator and became a care coordinator for the past 5 years, or for 5 years. And then for the past 3 years, she's been an SBIRT trainer through a SAMHSA-funded grant. And she currently provides training and technical support to the AETC and BHIP sites in both the New York and New Jersey areas. So welcome, Lori, and thank you for being with us.
Thank you. Should we wait a little more or get started?
I think you can get started now. People might funnel in as they come, but you can go ahead and get started.
Okay, and everyone sees my screen right now, and hopefully you can hear me well.
Yes, yeah. And again, actually, if people have questions, if you want to throw them in the chat box as we go, we can circle around to them at the end and make sure they get answered as well.
Okay, great. All right, oops, jumped ahead. All right, so good afternoon, everyone. Again, my name is Lori Sadowski. Thank you to the BHIP team for having me here. So I'm glad to have the opportunity to follow up on the SBIRT overview training. I hope you all had the chance to look through that webinar. If you haven't, I'm sure your coach can get it to you so that you know a little bit more about SBIRT, more of the details of it. Because really what we're talking about today is implementation, and I want to go over some of the screening tools that I think would be really helpful at your sites. Okay, so just to review, so SBIRT is an intervention. It's based on motivational interviewing, and it breaks down to 3 different parts. Your first part is screening. So this is going to be universal screening for alcohol, drugs, prescription drugs. It also can be universal screening for depression and anxiety. And today we're going to look at 2 specific screening tools, one that is for depression and one that is for alcohol, tobacco, and other drugs. The second part is your brief intervention. So I know that a lot of you have had MI training. There was a webinar, and there was also some time for you to practice. And that's really important because to know MI skills is one thing, but to be comfortable using them and to know when to use them and feel comfortable is really important. And you're going to want that for once you do the screening to actually have a conversation. So I just want to point out here that SBIRT, this isn't treatment. So this isn't that, we're expecting sites to be providing treatment based on screening results. What you're really looking for is that you screen, if there's a positive screen, that you're comfortable to have a couple questions, talk about it, and see where is that person in right now. Are they interested in a referral, or maybe they just want to follow up with you, and so on. Okay, so for screening, like I mentioned, we're going to talk about 2 specific screening tools, but I just want to start with some key points for screening. So so for the past 3 years, I've been doing SBIRT training. This was for residents, PA students, midwifery students, and then also clinics in New York, New Jersey area. So one of the things we always start with is ask permission. It's really important how you introduce the screening. So, it really impacts how that screening is going to go and how people are going to respond to it. So asking permission is something really great to give people a little control. If you think about most of your doctor visits, you don't really have the opportunity to say, yes, I want to answer those questions. No, I don't want to. But it's really great when we're talking about substance use and depression, give that option, explain what you're doing and why you're screening for it. When I was a care coordinator, we did intakes, and I would always say to people, these next couple questions are about your sex life. If you're not comfortable, you don't have to answer. These next couple of questions are about alcohol and drugs. You know, if you're uncomfortable or you'd rather not answer it today, that's okay. You know, we don't want people to feel pushed. And if we give people the opportunity to say, yes, I'm comfortable, or no, I'm not, it's just giving them a little bit more control. And I think it's really important. And I can say that really only one time did I have somebody who actually said, no, I don't want to answer anything. And that was okay. You know, he didn't know me, he wasn't comfortable, and that was his choice. The second point is you want to screen everyone. So we're going to talk about later, you know, really making a workflow for SBIRT at your sites. So this is to make sure that every patient at maybe every intake, maybe annuals, reassessments, they get screened. That way we don't have to worry about people falling through the cracks. And by using the validated tools we're going to talk about, you're making sure it's standardized. So every provider is using the same screening and every patient is getting the same comprehensive screening for behavioral health. And then it's also important to know that, you know, sometimes people hear screening and they think, oh God, I'm going to spend a long time on all these questions. But a lot of these screenings have a pre-screening in it. And with those, you may be able, you know, you ask a question, the patient says no, that might be the end of the screening for you. So it's important to know that, you know, depends on the patient how long you're going to have to spend on each of these screenings. And again, to go back to, this is all about MI, you know, you want to be non-judgmental. If you're in some way kind of projecting judgment about substance use, about mental health, then it's going to be hard for people to maybe feel so open. So it's really important that, you know, when you're practicing and you're thinking about SBIRT, that you're really making sure all the staff are comfortable, that they feel comfortable enough asking the questions and knowing who to turn to if they need, you know, somebody else to talk to, if they need a little bit of backup. Understand, you know, we want to be empathetic. You know, we see patients for such a short amount of time. You know, we can only know so much about what's going on, and we just want to always show that, you know, we want to learn about them. We want to understand what they're going through. And I wrote down here nonverbal. You know, we worked with a lot of new students, and, you know, they didn't understand certain things like body language is really important. You know, how you're sitting with somebody and how you say something, what you're saying, what your body language says, what your facial expressions say. You know, that really all impacts the screening and sets the tone for the rest of the SBIRT intervention. And then just a note about the substance use screening. You know, the one we're going to go over today does include alcohol and drugs, but at your site, you may already be using the audit or the DAST. So it's just important to make sure that you're screening for everything. It may seem kind of time consuming, but at the same time, we know that if we're missing certain things, you know, if somebody is using substances and it's impacting their health, but we're not asking about it, that could be really creating a lot of problems. Okay. So the first screening tool is the depression screening tool. So you may know it as the PHQ-9. So this screens for depression. And I think that some of you may already be familiar with this. So you know that the PHQ-2 is kind of that pre-screening. So like I said, you know, you do the first two questions of the PHQ-9, that's PHQ-2, if your site is doing it that way. And if it's 0, then you don't have to go on. However, the PHQ-9 does assess for suicidal thoughts. So if you're not doing the whole PHQ-9, you want to make sure that you are still screening for suicidal thoughts, even if you're not doing the whole thing. So I included this link because you can actually go and do the PHQ-9 directly on this website, and it will score it for you. Or, you know, some of your EMRs might have the option to enter it into your system and have it as a smart form or in a note. But the link is here. It's also on the last page. And so you can go and actually see how you can score it. And, you know, you put in the answers and it will score it for you. Okay, so if you've seen the PHQ-9, then this is going to be a bit of a review for you. If this is something new, then these are the 9 questions that are part of this depression screening. So what this is asking about is in the last 2 weeks, how often how often you have been bothered by the following problems. And then the person says, not at all, several days, more than half the days, nearly every day. And as you go down through these questions, their answer determine the score, and then that scoring kind of tells you, what's your next step. So, as you look at these questions, you could see that these are really prompting you to have a great conversation. Your brief intervention could be about a lot of these responses. Something like somebody tells you they're having trouble falling asleep or staying asleep, or they're feeling tired, they don't have a lot of energy, they're not enjoying the things that they're doing. This is kind of a closed questionnaire. So when you're done, you want to use that information, those yeses, to kind of lead to your next conversation. Maybe you want to understand a little bit more about the sleep issues that they're having, and how is that affecting things like getting up in the morning, going to school, going to work, taking care of their family. Maybe it's impacting their relationships. So you have these questions and they're setting you up for a good conversation in the brief intervention. So that's questions 1 through 4. And then 5 through 9, again, you have more questions that, can kind of lead to conversations, poor appetite or overeating. If you're a provider and someone's telling you that they're overeating, maybe this is a conversation about high blood pressure, diabetes, something, if those issues are already there, then the screening is, again, leading to more conversation. Feeling bad about yourself or like you're a failure, difficulty concentrating. If that's something that someone's struggling with, that might affect, again, their work, their school. So just something to think about, as you're going through this screening, that these aren't just questions you ask and then forget about. You want to think about, these answers and how is that going to lead to your brief intervention conversation. Okay. So this is the scoring for the PHQ-9. So you can see that it kind of breaks it up into cut points. So on the bottom chart, you have 0 to 4 is none, 5 to 9 is mild, 10 to 14 moderate, 15 to 19 moderately severe, and 20 to 27 is severe. So this is all from that website, that link that you have. You can go and check it there and see the same information. You may at your site decide, you may want to come up with your own proposed treatment actions. This is laying it out so that you can see what are some options and what to follow up on and how to follow up on it. But this is just giving you how the PHQ-9 is scored and give you an idea of what you want to think of next. Of course, understanding that just because somebody, let's say, does get a 23 and they fall into severe category, yes, you may think that they should get a referral. Maybe you feel like they should be talking to somebody, a mental health counselor, a psychologist, psychiatrist, but it's all about what that patient is interested in and what that person is ready for. And so that's where your brief intervention is so important, to understand where are they, how do they feel about this, what are they really looking for. So that is the PHQ-9. I know that, this may be new for some of you. This may be something that you're already using at some of your sites. Just wanted to go over it so we're all on the same page about the specific screening tool. So next we're going to shift over to the substance use screening tool. So I just want to start with just a little bit of education that you might want to double check with your patients before you're asking these questions. So this is just how much is one drink. So, you want to just double check that when you're asking the screening questions that you clarify first, one drink is 5 ounces of wine, 12 ounces of beer, and 1.5 ounces of spirits or hard liquor. So that might be something kind of surprising, or, that may be something to discuss in a little bit more detail, because we know that a lot of stores and bars, they actually sell beer in 12 or 16, 24 ounces. People can buy 40 ounces of beer at the store. Sometimes, you go to a restaurant and they want you to come back, so they're giving you more ounces of wine because they're, the heavier pour, things like that. And especially with mixed drinks, because we know that a lot of mixed drinks actually have more than one shot. So just understanding that, what your one drink and their one drink are the same. A lot of clinics have actually taken this information or similar information. You could laminate it. You could have it in, even in your waiting rooms or in your clinic room, so that it's a little bit of education, and it also may help make it a little bit easier when you're doing your screening. So the screening tool, the TAPS, is a tobacco, alcohol, prescription medication, and other substance use tool. So some of you may have heard of this before, or this may be something new. I know for myself, I was much more familiar with the audit and the DAST. But the drawback of both of those was that you had to do 2 separate screenings. They were long screenings, and a lot of the questions kind of were very similar. So what's nice is this screening tool kind of pulls it all together. Like the audit and the DAST, this could be self-administered, or it could be given by a healthcare professional. And depending on your site, you want to think about, who is that healthcare professional? Is that going to be a provider, a nurse, a case manager, community health worker? You have to figure out where does the screening tool fit best into your clinic. Again, it's nice that it assesses for many substances, so you don't have to do so many screening tools. And like the PH29, this is also an online format. And it goes even a step further. So basically, based on the answers that the patient gives you, that determines what the next question is. So if someone says no to alcohol, there are no other questions about alcohol. Whereas if another patient says yes, then there are some follow-up questions to get a little bit more information, because this tool is trying to figure out risk levels. And again, what is the recommended follow-up? Is it a brief discussion? Is it, something more in depth, or referral, things like that? Okay, so the screening tool, like I said, has some preliminary questions. So these are the 4 questions that it will ask. And based on their answer, that will determine if there are follow-up questions or not. So the first one is, in the past year, how often have you used tobacco or any other nicotine delivery products? The second, how often have you had 5 or more drinks for men or 4 or more drinks for women containing alcohol in one day? How often have you used any prescription medications just for the feeling, more than prescribed, or that were not prescribed for you? And how often have you used any drugs, including marijuana, cocaine, or crack, heroin, methamphetamine, and so on? So if you have a patient and they say no to everything, that is the end of the screening. If they say yes to all of them, then each category has its own follow-up questions. I really like this tool. I suggest you go, the link is at the bottom of the PowerPoint. You can go in there, you can put in different answers and just see what it recommends. And I think it's a really great, very clear way to know what to do next. So for maybe you have some staff members who are new to asking these questions and they're not really sure, it's very clear. In the past, people were told to use the CAGE questions, and they are easy to remember and, cut down, annoy, guilty, and eye-opener. The problem is it wasn't super clear what was the follow-up, whereas this tool is very clear about what you should do. I do just want to say that screening tools and SBIRT in general, the evidence is very strong for alcohol. It's also validated for tobacco. Depending on where you look, you may say marijuana. Some of the other substances, the evidence isn't as strong. But like I said in the beginning, this isn't treatment. This is really beginning the conversation. So someone in the clinic asks the question, you find out that patient is using a substance, and it opens up the conversation to talk about harm reduction. Maybe the person's interested in stopping completely, maybe they're not. We're going to figure out where they are and what information we can provide that makes sure that they have the information and access to resources that they really need. So like I said, the TAPS will give you very clear responses about what is their risk level. So I went in, I did you know, I did the test and answered no for everything. And so this was the output that you get, you know, that there's no use in the past year and the risk level is nothing. So, you know, what I like is that it doesn't say, okay, just move on. You know, you do want to reinforce this behavior. You want to say, you know, it's good, you know, their past history, you know, you can include whatever it is that you want to. I like that it also does mention, though, to keep in mind that, you know, a person may not be using substances, but there may be other issues. There could be depression, anxiety, other psychiatric disorders. And so that's why it's important that we don't just screen for substance use, we don't just screen for depression, but we make sure that we're really covering both. Okay, I also went in and answered the questions to show that the person has been using marijuana and at least one of these other substances. So ecstasy, Molly, poppers, LSD, mushrooms, one of those. And so the result was saying that it's the risk level is problem use. And so again, very clearly it lays out for you what's the suggested action. And this isn't to say you have to follow everything that's there. You have to agree with everything that's there. It's just giving you what is recommended by the NIH who developed this. So things like, you know, assess for substance use disorder. You may want to express concern. It says recommend cessation. It could be, you know, maybe more likely is discuss harm reduction techniques. You may want to offer the idea of counseling or other treatment options. And then, you know, discuss some risk reduction counseling. So advising somebody not to drink or use drugs and drive, maybe talking about how their substance use may affect some of their decisions about sexual risk behaviors or accidents. And then again, you know, depending on what it is that they're using, talking about this harm reduction. So I'm sure you're all familiar with different methods. Maybe it's access to a syringe exchange program. Maybe it's having naloxone. Maybe it's making sure that they're using around other people in case anything happens, you know, and so on. Okay. And they're also, again, I answer these questions to get to the higher risk category for alcohol. And again, it goes through, you know, some of their recommendations, you know, to assess for substance use disorder, express some concerns, discuss about the risks of alcohol and driving. And it just has some suggestions. Again, on the website, you could do this. You could answer the questions many different ways to get the results that you want to see what they recommend. And so I do like that the website kind of makes it very clear and has some good suggestions for what you can do. And of course, you know, you can figure out at your site if you want to use the website just for scoring, or if you want to use it to actually like follow through and go with all of their recommendations. So those are the two screening tools. So that was the PHQ-9 for depression and the TAPS for substance use. If those are new, like I said, definitely go check them out. If you're going to be implementing them at your site, you know, you want to make sure that you and your staff have a lot of time to get to know these tools. You want to practice them. It may seem like they're just a couple questions, but the more comfortable that everyone is with the questions, the better the screening will go, and the more comfortable the staff will feel, which I think will lead to the patients feeling more comfortable too. So I've been to a couple different SBIRT trainings. The New York State Oasis, they had a several-day SBIRT training the trainer that I went to, and they had us literally go through question by question through the screening tools to really make sure we're comfortable. And, you know, so we're not kind of like stumbling through it when we're actually sitting there with a patient. So I definitely think, you know, more training either through BHIP, through your coaches, or perhaps on your own internally, just figuring out ways to make sure people are comfortable with all the screening tools that they have, and that they kind of come up with a script of how to introduce it. You know, how do they ask permission? How do they normalize it, saying this is a screening tool we ask every patient during every annual. during every intake and so on. So if you have some questions about this, we're definitely going to have time at the end for questions. And like I said, there's more trainings to come. This is really just kind of an introduction to these two screening tools. And then we want to talk about some workflows and how to actually get this to work at your sites. So the next part is the brief intervention. And I know that you've had the MI webinar. So this is really a review, not so much training. MI is something that, it's something you go to a training and you learn, but the best way to really master it is you have to use it all the time. So multiple visits a day, make sure that you're using this so that you feel comfortable with it. And so you can use these skills when you're talking to your patient after you do the screening. So you may want to provide the screening tool results. So for example, you go through the TAPS and, it says like high risk category for this. And, kind of find out, what does that mean to the patient? Are they surprised? Are they not? Do they feel like maybe that, that's inaccurate or so on? And then always using those skills. So hopefully you're all familiar with open-ended questions, affirmations, your reflections, your summaries. So this is how you ask a little more. The screening tools, as we saw with the PHQ-9, it's very kind of yes and no, cut and dry. But again, you might want to ask, well, how is the disruption in your sleep affecting your ability to get to work? And, how is the fact that you feel so tired and drained, affecting, how active you are with your kids and so on. So you just want to use those questions as a foundation for a really good discussion in this brief intervention. And again, this isn't treatment, it's really to get people to start thinking so they can, start thinking about, do I want to make some changes to how much I'm using one substance or another? What would that look like for me? What has worked? What has not worked? Who is supportive? Who around me may also use this substance that would make it more difficult? Just to get some information to understand what is the next step. Is it a referral? Is it to check in with somebody at the clinic? Maybe they would prefer to speak with a peer. Maybe they'd rather be in a group setting, individual counseling, so on. But you have to have this conversation before you kind of jump along. So, I really just want to stress the brief intervention is necessary. So it's not SBIRT if you're just screening and then, documenting it and not doing the brief intervention. It's also not SBIRT to screen and jump to referrals. Unfortunately, I've seen this happen. Part of the job that I had with the last SAMHSA program for SBIRT was that I would go into clinic settings and observe some of the residents that were with patients, and I saw one of the residents do a really nice job of screening, went through the audit, found out from this patient that she was having 2 40s a day and a pint of vodka on the weekend. She was very forthright. She told us that, she has trouble getting up in the morning. She wishes she could do more with her day. Really great screening, and I thought the provider did very well. And then as soon as the screening was over, he was like, oh, I really think like you have a problem with alcohol, and I really think you should talk to one of our counselors. And it was so disappointing because he missed the intervention. He missed the discussion. And so she immediately, shut down, and she was just like, I gotta go. I gotta, get my medicine. And she wanted to get out of there because he jumped to, labeling, and he jumped to a referral without understanding, what did she want? How did she feel about how much she's drinking? What were some of the issues that had come up? And she gave really good information. He could have asked more about the fact that she doesn't get up in the morning, that she, wishes she could do more. She mentioned that her boyfriend complained about how much she drank because, she would do things that he thought were embarrassing. And so that's what the brief intervention is. You want to discuss what happened in the screening tool and just understand a little bit more. It says here, you could discuss the pros and cons of behavior change. If that doesn't feel comfortable, and some people say, you want to include it or you don't, you just got to figure out like what's working for that person, how they feel about it, and where are they. So the last line, assess readiness to change. This all kind of goes back to stages of change. So if someone's in pre-contemplation and you do a screening and they score, a positive result that's high on the TAPS, I would say don't expect to be giving a referral that day. That means that, there's a lot of conversations that have to come up. And the same could happen with a depression screening. You could have somebody who, yes, they have a positive score, but they're not really ready to go and talk to somebody. So, it's important to just make sure that you're using those MI skills. You're not being judgmental. You're not being judgmental about their behaviors, and you're not being judgmental about their decisions. It's just making sure that they know what's available and what harm reduction they could do right now to make sure that they're maybe using their substance in the best way, or if they are depressed, they have everything in place and they know who to reach out to and so on. So the brief intervention in SBIRT, we kind of talk about the whole intervention as a brief negotiated interview. So the first thing is always build rapport. I mentioned this in the beginning with the screening. That rapport is really important when it comes to how somebody's going to respond to this training, to the screening, and how that's kind of going to go. Provide information and feedback, I'll mention in 1 minute. And then enhancing motivation. So if somebody gives you some change talk and they're interested in making some changes, they're maybe interested in some kind of referral, you want to really build on that, focus on people's strengths, focus on the positive supports that they have, and kind of move with that. And then the last thing is negotiate a plan. So that's kind of your last step. Like I said, the person who screened and jumped to referral, he missed that in between step. So the role of whoever is doing SBIRT is, I say provide feedback with permission, asking somebody, is it okay if I give you some information, rather than, I think sometimes we have a lot of information and we just want to help people. And so a lot of MI and SBIRT is kind of stopping that fix-it attitude and really working with, what does this person feel about it? What do they want? What has worked for them in the past? What is not? What do they think would actually help them to make some kind of change? And so all of this is kind of about that. We're helping people explore their options. We're trying to understand where they're coming from, and we're there as a support. MI, they always say it's a dance. It's not you dragging someone forward. It's not you pushing someone forward. It's really understanding, where do they want to be? Where are they? Where do they want to be? And then how do we support them in that? And so one way you can provide some feedback or some information is you can do this elicit, provide, elicit. So you could say, what do you know about the impacts of drinking? And let them tell you. And then you could say, could I tell you some additional information? And then once you do that, you could say, how do you feel about that? Or what do you think about this new information? And so it's a way to, you're providing feedback in an MI consistent way. And you're also making sure that, you're not providing information that that person already knows. So those are just a little overview of the brief intervention. Again, it's a longer training and it involves some practice. So I hope that when you're ready to implement SBIRT, you really think about having your staff members do role plays. Role plays are the best way to get people comfortable with it. And, you could do role plays with different outcomes, different patients that you actually have, and think about like how you want to help your staff to support them so they feel comfortable with this. Okay, so referral to treatment. This is the last part of SBIRT. As I mentioned, it's very dependent on what does that person need, what are they interested in, and you know, it's really just dependent on the person, not so much what we may think that person needs, but really what is it that they're open to, they're interested in. So there are a lot of different referral options. So, you know, we're all familiar with individual or group counseling, medication-assisted therapy for substance use, and medication for something like depression. And then all of the options with a STAR, you know, this could be something that's done in-house. So a lot of times we think about external referrals, but there also are a lot of options for things that we could do internally. You know, we could have peer-led programs. We could have groups that are peer-led. We could have counseling within our own clinics. There's also complementary wellness. It's understanding that substance use and depression, you know, there also may be some other options. Maybe it's yoga, walking groups, understanding things about, you know, diet and exercise or acupuncture. You know, there's a lot of different things that may be options for you to do at your own clinic for the people that really aren't interested in outside referrals. And just, you know, it's important when we're making referrals to think about that warm handoff. So really building up the confidence of the next person that you're making that referral to, and so that they feel confident in whether that person is internal or external, you know, really focusing on that handoff and how it's done. And just some things to consider when you are making referrals, you know, and this is something we'll talk a little bit about with the, you know, the SBIRT workflow, but understanding, you know, who at your site is going to be the one to make that referrals. Is it one discipline? Is it one person? You know, who's really responsible? And I know that the BHIP team is working on making a kind of like a list of local resources so that you know what's available to you. It's really important that that stays up to date so everyone knows what are the resources that you can turn to. And then, you know, focusing on how do you improve referral appointment completion. So you do have the option of, you know, making sure it's one handoff. You also might want to take advantage of patient navigators and community health workers, because a lot of times, you know, people are nervous about going to a new place, and if they have someone that they know and trust, then that might make that appointment, you know, so much better. And especially if you have a good relationship with that external referral, that's going to make it even better. So it's somewhere that you know who you're going to speak with, you know that these people are going to do a good job. And so all of those things can really help with improving your referrals. Okay, now to the, you know, we talked about SBIRT and the different components. Now it's, well, how do you make SBIRT work at your site? And so every site that's here may have a different kind of layout, you know, how many providers you have, which disciplines, how everything works may be very different. So you really need to tailor the workflow and SBIRT to your site. So you want to think about, you know, who is going to be doing the screening, which disciplines, how often are you going to screen? Is this annually or quarterly, biannually? You know, what works for your site, what makes sense? You do have to think about how you want to document it, and then document both the screening and your referrals. So I'm sure a lot of you already have, you know, some screenings that you're doing. You already have a system for referrals. So it's just incorporating SBIRT into that system and maybe making some tweaks to make sure it's, you know, it's inclusive. So what I'm including here is an example of a workflow that was developed by another site. So the way that they did this was they decided they wanted both their primary care providers and their case managers to be doing several screenings. So in that top blue box, you can see they wanted to screen for anxiety, depression, alcohol, and drugs. And so, you know, you don't have to follow the details here, but they basically just, you know, they wanted this slide is specifically for their providers, and they wanted them to do all the screenings. And based on the screening results, it determined who the referral is. So you can see here in the third row, it says, you know, refer to Floor, refer to Kara. Those are two people that were their actual referral people. So one person was a substance use counselor, one person was their mental health counselor. And so this is how they created their workflow. Maybe you want to do something similar to this. Maybe you already have something in place. This is just one option, something to kind of guide you as you decide what it is that you're doing, and which of these screening tools you want to use. This next slide, for those, it may be a little overwhelming. There's a lot of arrows, but again, this is the same site, and this was their flow chart for their case managers. So they also wanted them to be doing these screenings at reassessments. We don't have to go through it. I just want to point out that in the third row, the blue rectangles, you can see it says telephone encounter smart forms. So the reason I like this workflow is it's answering a lot of questions. It's answering who's doing the screening. These are your case managers or screening. So the top, you know, these are case managers. How often are they doing the screening? Reassessments are every 6 months. So they're doing every 6 months. What is it that they're screening for? They, again, were doing PHQ-9 and the GAD-7, which is for anxiety, audit, and the DAST. And it tells you where you're documenting it. So they wanted these to be in their smart forms. The reason they chose the smart forms is because that's how their data person is actually going to easily be able to pull which forms are completed. So you want to make sure you're documenting somewhere where you can pull it, because you want to be able to show Department of Health, your grant funders, others, you know, this is all the work we're doing. Look at it, you can see all the screenings that we're doing. And at the bottom, you know, it does show you where you're referring. So I know it is a slightly overwhelming chart, but it's giving you a lot of information, and something that I hope is helpful when you start to think about, you know, what are you doing at your own sites? And I know some of you may be at different stages of where you are in your workflow. I hope this is something helpful, and definitely your coaches can give you some more information about it. Okay, so so you've seen that example of a workflow, and then thinking about, you know, for your own site. So what might be some challenges or barriers to putting SBIRT into your system? You know, what might be some supports for it? Maybe you already have you know, you already are screening for substance use, you're screening for depression in another way, and so maybe this isn't really such a big change for your site. It's important to understand, you know, how are patients going to respond to increased screening? You know, maybe they weren't asked these questions and now all of a sudden they are. So understanding how you want to introduce it. Again, it's the approach that's taken when you start asking those questions. And then really understanding, you know, how is staff going to manage the extra screening? You know, it may feel like a lot. They may already have a lot to do at an annual visit or an intake or a reassessment. And with that, you know, it's really having the conversation, you know, with yourselves and with your staff about why is SBIRT important? You know, why is it important that we ask about depression and substance use? What are the risks of not asking? What are the risks of not, you know, not asking, and maybe it's impacting this patient's health and we don't know, or it's really causing problems and we don't know about it. And, you know, again, it's who's going to be doing the screening, how frequently you want to screen. That's something you have to, you know, figure out what seems appropriate for your site. You want to figure out how you're going to document. So as I mentioned, that other clinic, they had smart forms, and that's how they are going to document it, and that's how they're going to pull their data. But maybe you have, you know, a different kind of EMR. Maybe you have pop-up tabs for your providers. Really depends on what you have at your site. And then also how you're going to track it. So once you implement this, you want to actually pilot it and then see, you know, how is it going. And then also keeping in mind, you know, you don't want to duplicate. So you don't want your nurse, case manager, and provider all asking these questions, you know, on an annual visit in one day. So who's going to do it, and how do we prevent duplication of existing screening and things that you have. And then any other ideas or concerns that kind of come up. So in summary, I know we kind of covered a lot here, but this is really just to be a foundation for a lot more one-on-one coaching, a lot more personalized training. You know, every site is going to have different disciplines, different plan for who's going to do the training and so forth. So just today was hopefully a brief review for you of what SBIRT is. You know, always using the validated tools. I really like the TAPS. It's something new to me, but I feel that it might actually be great because you could screen for multiple substances without actually, without having to use the DAS or the audit, which have 20 questions alone, and this one could be 4. The brief intervention is really so much about those MI skills. And then your referral to treatment, again, is case by case, and really look into what can you do on site. You know, we know that referrals sometimes don't work because there's wait lists, because places are far, they're not convenient for people to get to, there's childcare issues, finance issues, transportation. There's a lot of reasons why referrals don't happen. And so if you can think about what you can do in-house that can really provide a lot of services for your patients, that's great. You know, maybe there are also new grants coming out that could facilitate that for you. And then hopefully that workflow was helpful, perhaps a little confusing, but hopefully a good way for you to see how to conceptualize what's happening at your own clinic. And again, I imagine you're already doing some kind of screenings, so it's just kind of putting on paper what you're doing, who's doing what, who's responsible for screening, and also for the follow-up. And as I mentioned, you know, there will be more trainings. Definitely reach out to your coaches so that you can have some assistance with your workflows. If you want more training on MI or SBIRT specifically, you know, definitely reach out. That's what they're there for. The BHIP team really wants to make sure that SBIRT is something that you can add without it feeling overwhelming and without it being something that seems very burdensome, but really brings a lot to the kind of patient care that you're giving. So the 2 websites that have the different screening tools are listed here. Like I said, you can go there and kind of put in different answers, get different recommendations, and I hope that was something helpful. So if we have some questions or discussions, we can do this either, I don't know, by chat, or people want to ask.
Hey, Lori, I've got a question for you. First of all, thank you so much for that. That was really fantastic. It was very understandable, and those workflows are super helpful for us to guide folks with. So really appreciate that. One question. So we've got a mix of folks in our collaborative, as you know, some that are community-based organizations and some that are clinic-based. Some of them work really close together, and some of them are not as far as the bridges between their clients and patients. Some of our CBOs may see folks more than one time a month. Is there a recommended amount of screening you would think they should be doing? Is this something that's like a monthly encounter or something more like quarterly or every 6 months?
I think, I mean, every site can kind of figure it out themselves. I think monthly, even quarterly might be. Monthly, I think, is too much. I think if you wanted to do quarterly, quarterly could be an option. It's also about, you know, if you're seeing somebody often, you might kind of know what's going on. You may be having just conversations outside of the screening, but I think a lot of the sites are kind of choosing annual or every 6 months.
So they could like potentially tie this to their annual reassessment or their Ryan White certification to kind of systemize this in a way for them. And then should they be communicating with like a CBO in a clinic, if they know they have a lot of shared clients and patients, should they be communicating back and forth so as to not duplicate this? And if one environment does it, should the other repeat it on their based on their frequency, or should they just take the scores from the other organization and sort of document that in their own way so that they're informed by it?
Good question. So a few things I'm thinking. One might be that different sites may have different grant requirements, so I don't know if they have to do their own. The other thing is, sometimes, maybe somebody may feel a little more comfortable with one person versus another, and that's just normal. But I think, if there are sites like that, then I think it's really great to communicate, because you wouldn't want somebody to go in and have this screening on Monday and have the same screening Wednesday. So if you are working closely together, then you would kind of know where things are, and so you don't have to duplicate it so much.
Okay, cool. Yeah, because a lot of our sites, I don't think, at least in the grants I'm familiar with, they don't have to do it themselves. They just have to be aware that it was done and then know if there was action taken on it. So I coach the CBO, so I'm always trying to figure out, should they do this? Should they help the clinic? Should they just take action on it? So thank you for clarifying that for us.
Sure, great.
And then do we have other questions? I'm also going to put in the chat box a survey. Anybody who participated in the webinar, if you could fill that out, that just helps us as well, kind of a evaluation survey. So I put that in the chat box. And while we're wrapping up, did anybody else have questions for Lori or comments? You can either unmute yourself or put them in the chat box as well.
How soon can we get you on all the sites to teach us how to do this?
I don't know. I would say I'm very glad that the power stayed on, because we had a power outage this morning. So
I think one question, so for a big SBIRT training, what kind of time commitment are folks looking at here? Like if they wanted to do this on site, who should they bring? What kinds of persons should they have? And how much time should they think about dedicating to it?
For most of the sites, we've done 3 to 4 hours, and they've brought everybody. So, to have multiple disciplines, your providers, case managers, nursing, it really depends on who's going to do the screening and how it works. But I think you need a lot of time, because a lot of it really is that MI part, and it's practicing. So it's, it's more than I know what an open-ended question is. It's I know how to use that open-ended question in this discussion. And then role plays, and, maybe even having cases brought up. It depends on the site and what they feel. If a site's really comfortable with MI, you would spend a little less time on that, and you could focus on, case examples, and figuring out what are those system issues. It depends. One of the sites they did, I think overall we did about 4.5 hours. It was, 3 1.5 hour sessions, an intro to SBIRT, then practice, and then really getting into what is the workflow here, and letting people talk about what they like about it and what they don't like about it. We had some case managers who, were feeling overwhelmed with screenings already. So you have to keep that in mind, because they're the ones that have to do it. And so, I think it's great to have everybody in the room, because it is like a multidisciplinary process. It's not one discipline, and it shouldn't be only one discipline, working on it.
Okay. And I have another question.
Yeah.
So New Jersey has medical marijuana. Has that, any advice on what to do there? Because I think a lot of folks are up in the air about this, especially considering that I think confidently I can say this, there are people who are on medical marijuana who may abuse it once they're on it in a different way than it's intended. How do you recommend sites who have patients or clients in that space? Should they continue to sort of screen for marijuana in the traditional sense, or do they have to kind of sort of almost like exclude them from the denominator when you get to that marijuana question.
Interesting. I don't know if the screening process has caught up to the fact that there is,
Yeah.
I think you would, I mean, it might make some of your screenings, it may give you kind of skewed results, but I think you could phrase it the same way of phrasing, you know, prescription drugs. Are you using it maybe beyond what's prescribed? And, you know, I think thinking about it as, you know, there may be people who are taking it exactly as prescribed, and that's good. If it's helping them, that's awesome. And if they're using it beyond that, understanding, you know, kind of what's happening. So yeah, the screening tool would probably, you would end up with a positive, and it would be high because they're probably using it every day, multiple times, or at least, you know, once, twice a day. But I don't know, I think it really affects more the screening result, more your brief intervention. So, and it's the same with, you know, I think just marijuana in general. You know, a lot of people don't see it as something that's negative, and it doesn't have to be. There's many people who maybe smoke marijuana at night and then they get up and they do what they got to do. And so it's not, you know, it's not meant to be something punishing people, but understanding, you know, who can handle this and maybe who's kind of struggling.
Got it. So it's more of like having somebody look at it to determine, like, is there problematic use versus just use?
Right.
Okay, cool. Yeah, we get that question a lot with all the shifting landscape in Jersey. And so I don't think there's any good guidance on what is appropriate use of marijuana coming out of the docs. I've asked a couple of the providers to sort of explain that, and it gets really individualized, they said. So it's kind of like an area where we don't want to stigmatize someone who might be potentially using something, but at the same time, I don't want to miss something that could be driving negativity in their lives as well.
Right. Yeah.
Cool. Well, thank you so much. I really appreciate it.
You're welcome.
Yeah, thank you, Lori. Thank you. And as a reminder, everybody, that survey is in the group chat. If you have questions about this as you think on it further, please just reach out to your coach, and we can help you either ourselves or kind of funnel those questions to Lori as they come in. Thank you all for coming to our webinar, Be Safe with the Snow, and thank you, Lori.
All right.
Oh, it looks like we have one more question if you have a minute. Oh, well, maybe not. Working in a CBO, NJCRI, we screen every 6 months using the PHQ-9 and TAPS during the reassessments. And we also have behavioral and substance services on site, and that team screens accordingly. Good. Sounds good. And they said great webinar.
That's
so
awesome.
thank you, everybody.
Okay. All right. Thanks.